But more recently, people have started to make resurfacing implants out of metal. And of course, with a metal shell, you can make them very thin. So these, to implant these, you basically replace the cartilage with metal. And we have used really quite large numbers in young active people, and they do work very well in young active patients in general. And they probably give a slightly better feel and function than a normal hip, because you preserve much more of the normal hip. And they certainly wear very slowly, probably not quite as slowly as the ceramic, but they wear slowly. But unfortunately, we've had quite a few problems, particularly in women, with wear. Because if you do get any problems, any metal wear debris, it can actually cause quite a lot of damage to the soft tissues around the hip. And that's probably because the edge of the socket wears on the head, and you get a focal area of deep wear. So actually we've now stopped using resurfacing in women, but we still use it in large numbers in the younger, more active people.
Why the difference?
We don't know. We think it's probably to do with the flexibility, particularly with young women. Their hips are much more flexible, they can get their feet behind their head, and if you get your hip in a funny position, then you get the edge loading and it wears. These are made to a very high tolerance. The sort of area, the surfaces are very smooth, and you get a film of sort of fluid lubrication between them. That stops the wear, but as soon as they wear on the edge, they wear catastrophically. I think it's to do with the greater flexibility of women. Also, they're small. And finally, perhaps the most exciting recent development is that this plastic bag material, if you actually irradiate it, you split the molecules of the plastic bag of the polyethylene, and they join back together to make much bigger molecules. And this highly cross-linked polyethylene, which has huge molecules, wears very much more slowly. And we're starting to use this in much larger numbers. And in fact, for the last 7 years, we've been trying to measure how much it wears, and we can't. We use a stereo X-ray system with an accuracy of about 1/10 of a millimetre, and we cannot measure wear over 7 years. So this is really wearing incredibly slowly. And because it wears so slowly, we can use relatively big balls, which in many ways give a better functional result. So anyway, that's a brief review of what's happening in hip replacement. So now, maybe if you don't mind, we will change to knee replacement. I said that hip is a very easy joint. It's a ball and a socket and easy to replace. Unfortunately, the knee is far from straightforward. And I've got a little model here that's rather destroyed that does show some of the key features of the knee. Firstly, on the outside of the knee, we have two ligaments that we call the collateral ligaments. And in the inside, in the middle of the knee, there are a pair of cross ligaments. I think you can just see them here, that stop the thigh bone, the femur, moving backwards and forwards on the tibia. And they're called the cruciate ligaments. And they're the ligaments that footballers always rupture. You probably all remember seeing Michael Owen rupturing his cruciate ligament. But it's the cruciate ligaments in the knee that really control the way that the knee works. And you have to have well-functioning cruciates to get a well-functioning knee. And also we have the cartilages, which are these things, the menisci. I don't know whether I can show you them. Yeah. Two little round semi-lunar discs that spread below, and here you can see this disarticulated, the cruciate, the crossed ligaments in the middle of the knee. But anyway, so that's the structure of the knee. The conventional approach to the traditional total knee replacement is shown here. We have a large chunk of metal that goes on the end of the femur, rather like, I don't know whether I can show you, but it just fits onto the end of the thigh bone, and a metal with a layer of polyethylene goes on top of the shin bone. So if you articulate them together, that's a total knee replacement. I think you can probably see it there, a total knee replacement. But what you will have observed is that to get it in, we've actually had to remove the key functional elements of the knee, which are the cruciate ligaments. So actually, despite our best endeavour, these total knee replacements don't really replace function well. They work very well in the elderly, but for the younger patients, particularly the sort of people wanting to do sport, they don't work so well. And that brings us on to partial knee replacement. And here is an example of a partial knee replacement. And you can just replace the damaged bit of the knee. And the great advantage of this is that you can keep the normal bit of the knee, and it can get in focus. Right, sorry, this is a partial knee replacement, and you can see that the metal and the plastic bit is only on one side of the knee. So we're just replacing the damaged bit of the knee, and we keep the rest of the knee, and most important, we keep the ligaments. And those that you were observant will have noticed in Andrew's pictures of arthritis, almost all of them only occurred in part of the knee. And it is extraordinary, about 80% of people with severe arthritis in the knee, it's mainly in one part of the knee. So you can actually just replace the damaged part of the knee, and if you do that, you keep the rest of the knee, particularly the ligaments, and you end up with a well-functioning device. And the partial knee, of course, that we use here is the Oxford knee, that many of you will have heard about. This is an example of an Oxford knee. This was first developed about 30 years ago by John Goodfellow and John O'Connor, who have both retired, but we still see a lot of them. And over the years, we've been working on them on this and continue to work on it. It has one particular feature that most other knee replacements don't, and that is rather difficult to show you. You can see that. But this plastic bit, this we call it a bearing, is free to move. And that is very useful because it allows the knee to rotate, and also as it bends, the bearing moves backwards and forwards. And this bearing has large areas of contact with both the upper and lower surfaces, so it wears very slowly. And in fact, this design of knee replacement has far less wear than any other design of knee replacement that exists. So it is particularly good for young people because it doesn't wear out. And also it's very useful because it provides good function. So we have worked for many years developing and improving the Oxford knee. And about 10 years ago we realized that it's actually rather obvious, but the device is small. We realized that we could put it in through a small incision. Originally we put it through a big incision like a total knee, but in fact we copied an American, first of all, who put it through a small incision. And we now implant this through a very short incision, which means patients recover very quickly. And in fact now this Oxford knee is used very widely. It's the most widely used partial knee replacement. So this is the standard one that's used to replace the inside of the knee. We've always had great difficulty, so we call this the medial side of the knee. And arthritis almost always begins on the inside of the knee, medial side of the knee. Occasionally, perhaps 10%, it begins on the outside of the knee. And we've always had great difficulty replacing the outside of the knee. And the reason for that is that on the inside of the knee, which is here, as the knee bends, the thigh bone tends to sit right on top of the shin bone. But on the outside of the knee, as the knee bends, it tends to come right off the back, which is quite extraordinary, but not quite as far as that, but down about like that. You can see why it's very difficult to reproduce that with a half knee replacement.